Okay, let's jump right in by clarifying the absolute most crucial point. The core philosophy of this entire system is that it grades complications based strictly on the treatment required to fix them, not just how scary or severe the complication might look on paper. It's totally action-oriented. Think of it like this. We aren't grading the disease itself, we're grading the intervention we have to use. We've got a super focused roadmap today for rapid memorization. We're going to hit the classification table, its clinical application, some key memory pearls, those classic exam traps to avoid, and then we'll wrap up with a quick recall test. All right, part one, the Clavien Dindo classification. Let's get the foundational theory and the actual grading system completely locked into your memory. Take a mental screenshot right now because this table maps out literally every grade you need to know. Starting at the top, Grade I is any deviation from the normal post-op course that doesn't need specific drugs or interventions. Grade 2 steps it up. Now you need pharmacological treatment. Grade 3, that's when your patient actually needs a physical, surgical, endoscopic, or radiological intervention. And notice how it splits right there. 3A is an intervention without general anesthesia, and 3B is with it. Grade 4 jumps to a life-threatening complication needing ICU management. IVA for single organ, IVB for multi-organ dysfunction. And finally, Grade V is death. Oh, and here's a quick pro tip at the bottom. If you ever see a D suffix, that just means the patient has a long-term disability at the time of discharge. Moving right along to part two, clinical management and application. What's really fascinating here is how we take those raw grades and actually translate them into real-world clinical practice. First things first, keep this at the very front of your mind. This classification, it's not a step-by-step treatment algorithm. It's definitely not going to tell you how to treat your patient. Instead, it retroactively reflects the level of intervention your patient actually ended up needing. It acts as this, universal language so we can standardize how we talk about surgical outcomes globally. Let's see how this builds out in practice. Down at the lower tiers, Grade I basically just means observation and basic supportive care. No heavy-hitting drugs here. But the second we step up to Grade 2, we are firmly in the realm of pharmacological treatments. We're talking things you'll prescribe all the time on the wards, antibiotics, TPN, and yes, even blood transfusions. If you're prescribing meds beyond just routine prophylaxis to manage an issue, you've pretty much entered Grade 2 territory. Ascending that ladder of severity, Grade 3 is where we escalate from just giving drugs to actual physical interventions, maybe a drainage, an endoscopy, something like that. Grade 4 is when things get really critical. This patient now needs the intensive care unit, organ support, and management for single or multiple organ failure. And Grade 5, as we mentioned, represents the ultimate failure of intervention, which is death. Okay, let's shift gears to part 3, key clinical pearls. Because honestly, it's one thing to just read a table, but it is a whole different ballgame to actually memorize this stuff when the pressure is on during a busy ward round. So here is your ultimate shortcut for revision. If you strip away all the fancy medical jargon, you get this beautiful, simple list. Grade I, nothing specific. Grade 2, drugs. Grade 3, intervention. Grade 4, ICU. Grade 5, death. Literally, if you just burn these 5 keywords into your brain right now, nothing, drugs, intervention, ICU, death, you can reconstruct the entire Clavien Dindo system from scratch in seconds. And please, do not forget the golden rule for those subgrades, especially for Grade 3. A means the intervention happens without general anesthesia, so you're using local or maybe none at all. On the flip side, B means the patient absolutely requires a general anesthesia to safely get the procedure done. Make sure you keep that distinction crystal clear. Moving to part 4, classic exam traps. Examiners absolutely love to test the gray areas to see if you really get the mechanics of this. So let's look at the classic ways they're going to try to trick you. The very first trap is distinguishing in between IRA and IRB. Remember our golden rule. The distinction is based entirely on the need for general anesthesia. It is absolutely not based on how visually extensive or messy the procedure looks. For example, a really complicated, messy bedside drainage done under local is still just a third IA. But a super quick, straightforward re-exploration where the patient is intubated, that's a third IB. Don't let the surgical description trick you. Always, always look for the type of anesthesia. Now, treat this next point like a massive, flashing neon warning sign. Blood transfusion equals Grade 2. I know giving a blood transfusion feels like a huge, invasive physical intervention, but under Clavien Dindo, blood products are strictly classified as a pharmacological treatment. Therefore, it is always a Grade 2. Examiners will try to bury a blood transfusion deep in a long clinical vignette just to see if you accidentally upgrade it to a Grade 3. Don't fall for it. All right, part 5, quick recall question. We've gone over the theory, the shortcuts, and the traps. Let's see if you've actually locked this in with a rapid clinical scenario. Listen closely to this scenario. A post-operative patient develops an anastomotic collection. To fix this, you have to perform a percutaneous drainage, and you do it under local anesthesia. Based on everything we just talked about, what is the exact Clavien Dindo grade for this complication? Take a second. Think about the intervention type, and then think about the anesthesia. If you said grade 3A, you completely nailed it. Because if physical drainage was required, it immediately bumps us into grade 3 territory. But importantly, it was done without general anesthesia, using local instead, which anchors it firmly as a 3A. Understanding this exact logic is going to make you absolutely unstoppable on the wards. You've officially mastered Clavien Dindo today, but consider this. How might meticulously tracking these specific grades actually shift a surgical department's entire culture of safety over time? Think about that as you head out to the wards, and I'll catch you in the next explainer.